one SP, and we were evaluating it. It's in the distal sigmoid, and the P pattern, it looks CUD of 4 mostly. As you may know, this lesion sometimes has an increased risk of deeper invasion, as we have to think about this polyp like an iceberg. So we can see what is outside, but sometimes it's difficult to appreciate and assess what is inside.
Yes, thank you.
So we have already injected
Yes.
the polyp and raised the polyp. What have we used for the injection?
So, hello again, and it's a great pleasure to be with my friend Murino and Dara, and again in Saudi Arabia, and one of the best courses here. I thank Dr. Abed and the whole organizing committee for inviting us always. As he say here, we have this lesion. You can see it's like a granular mixed type, right? With a dominant nodule, and it's in the sigmoid. We change the patient position many times to have this nice view, and we start the injection. And if you look here, this is how it looks from retroflexion from the cecal side.
Hello, Dr. Ahmed.
Yes.
Thank you for this nice case. I have a question. Which cap are you using?
We will say everything, okay? So we were just assessing this, and for the scope, we use here X1 Olympus scope, and we use for injection solution what he was asking me, Dr. Roberto.
It's a monovisc.
Yes, we use a hyaluronic acid mixed with saline and very few concentration of adrenaline. And here we use ST hood from Fuji, and we'll use the hybrid knife flex 1.5 from Irby. We were in a discussion while we were offline with Dr. Murino. What is the strategy?
Yes.
And how should we approach this lesion? This lesion is not so large, but actually sigmoid is one of the challenging location, and you should have a good strategy for. So my strategy was to do incision from retroflexion and forward view, and try to connect them and open the side. And we actually start to do the incision from forward view, and we'll continue then work from retroflexion. The setting we use here is Endocut I 222 for the incision, and we'll use precise sect 4.5 for dissection. I don't know what is your setting and what you recommend for this.
Yes, so I usually have a different strategy because I do every procedure under cell and immersion.
Okay.
And I use usually flash knife 1.5, and my settings are Endocut I, and then 1, and then the settings are 1, 1, 4, and I use Swift Coag. It's 3.5. But it depends on the knife, it depends on the technique. So the settings can vary, and then also during the technique you can change it accordingly, depending on the scenario you have in front of you. It's a very dynamic procedure, ESD. So we need to know the Irby machine well, and we need to be able to change accordingly.
We have a question.
Yes, please.
Thank you. Hi, Al. Hi, Alberto.
Hey,
hi, Ahmed. It's
yes,
Edward Despot from the audience. Why have you chosen to start with an incision on the oral side? Wouldn't it have been a sort of more stable strategy to approach this lesion using the pocket creation method rather than an incision on the oral side?
So it's a matter of strategy, as you say, but here also we will try to make like a 90-degree rotation. We'll not do a circumferential incision. As you will see, we may be able to have also a good stable strategy here, but with a wide incision.
But why not the pocket creation method here?
Yeah, it's still we can use. Still we can use.
But why did you choose this? I'm asking you why you chose this over the pocket creation.
Yes, because I am more familiar with this, and I believe the most important to have a strategy for a stable location. I think all these strategy, all these technique are come from the pocket creation method. The concept of pocket creation method is to have like not circumferential incision and to have a good access to the submucosa as we're doing now.
So now
that's
you're
what we're
using
trying to
saline
do.
immersion, it seems, as
Yes,
well.
we try to combine all this. Yes.
Okay. Thank you.
Yeah, we have this similar discussion initially because when we discuss about strategy, I propose my plan would have been distal approach, pocket, then circumferential incision, tunnel, and then open the pocket. So I see where you comes from with your question. Any other question
Is
from
there
the
saline
audience?
in the pump or is it water? Because that's a very important thing.
Saline.
Good.
We have asked for saline.
Yes. Alberto, what are the advantages of the saline immersion irrigation technique?
So we have many advantages. 1 minute, okay. In 1 minute I will be very brief. The main advantages compared to water, and this is why me and Ed, we are quite pedantic about saline, is that there is more conductivity. And so the electricity travel better and you have a better incision and more precise. And in addition, the vision is improved with saline and the buoyancy effect is improved, as I will show you in the lecture. We have to give the line to another room, but we will be back soon.
What setting do you use in case of bleeding?
Yes.
Usually precise sect can solve most of these problems, but if we do a prophylactic coagulation, we use soft coagulation. Yes? Okay.
Yeah, that's fine. You can go. Bye, see you later.
Yes,
Close
with
the door,
Dr.
please.
Mathkour. Yes, welcome back, Dr. Ahmed.
Yes, hi. So
We can
let's
hear
show,
you.
yes. Let's show what we did. We open the cecal side as we planned, and then we open the oral side, and we have some problem to open the submucosal space here, so we did a traction. I'm not sure if you can see the traction here now. And after the traction, we have a nice view for the dissection plane. And we have just a small part to connect this oral side to cecal side we already opened. And we have some oozing vessels here. I still believe we can do with a knife. What do you think, Murino? We need to shift to grasper, or we can use under saline and do like this?
Yeah, we can control this bleeding with a knife. This is small bleeding, no problem.
Okay.
And in your expert hands, no problem at all.
No, just because we are beside me.
Yes. So yes, I think it was a very good decision to use the traction here because of the difficult access. And as you can see, the traction provided a better stability and better visualization of the submucosa. As you saw before, this polyp was very large and sessile, and therefore it was quite heavy. So it was quite difficult to approach the submucosal layer. And that's why, since we put the traction, we are basically flying with the dissection. We are flying so much that we were almost worried. I was worried that he was going to finish the procedure before you came back to our room. So that's the speed of the procedure now. Look, we were just discussing yesterday with my dear friend and colleague, Dr. Despot, on the plane. In our center, we have R0 resection in 86% of our ESD. And the recurrence rate, we only had only one, and this was because of R1 lateral. And if we have R0 resection, our strategies is 1 year follow-up colonoscopy.
Just to add one.
Any other question from the audience?
Okay, thank you very much, Dr. Ahmed and Murino. We can switch to another case just for the time.
Thank you so much.
Thank you very much. So can we switch to the
Just,
fluoroscopy room, please?